I am Nestor Raimondi from Argentina. Thank you for the invitation and congratulations for the exit the Congress. We start on table, sedation, delirium, and PIC 2. The first speaker is the Professor Theodore Jacques Iwashina, Dr. Jacques. The doctor is pulmonary and critical care medicine and professor, the Bloomberg distinguished professor and social science assisted in medicine in Johns Hopkins Hospital. Welcome to Dr. Jacques.
Thank you so much. All right, so let's, as we're bringing this up, is my sound okay? Can I get a nod from someone in the back that they can hear me? Excellent. All right, so I'm from Hopkins, so I want to start us at the bedside with two cases that I want us to think about and ask what are the right tools for helping us understand why this patient's stuck in the ICU. I think you'll recognize both of these patients. I think they're a fair amount of all of the work we do. So the first is a 74-year-old gentleman with esophageal cancer. Sorry, I just want to start my timer here. A 74-year-old gentleman with esophageal cancer undergoing palliative XRT. He aspirates during his XRT, he develops ARDS. Day two, he develops a alveolar pleural fistula. And day 3 to 8, we're able to gradually wean him from an FiO2 of 80% down to about 40%, but he gets stuck at about 40% and ends up on day 14 being trached. He's got other issues, including schizophrenia with psychotic features, COPD, and deconditioning. And my question is, how would you label the syndrome driving his prolonged ICU stay? And in particular, is it the same syndrome that explains why this 60-year-old woman, who had previously had well-compensated cirrhosis, is stuck in the ICU for 14 days? She presented with biliary septic shock, got a percutaneous Coley tube from our friends at Interventional Radiology. For 5 days, she was on high-dose vasopressors. By day 3, she developed ARDS, was in ARDS. To day 6, day 4, she developed acute kidney injury and was started on CRRT. Day 5, all the antibiotics that we were giving her for her percutaneous for her Coley gave her C. diff. Day 7, she had a yeast with urinary tract infection. This was in the context of a person who had myelofibrosis leading to pancytopenia, bilateral below-the-knee amputations, right shoulder fractures, diabetes, and morbid obesity. We know these patients. These are the patients for whom modern advanced critical care exists because these were unsurvivable injuries not that long ago, but as a result of the tremendous teamwork and the dedication that you in this room put into understanding them, we're able to save their lives. So how do we think about them? The standard tool for understanding why someone's stuck in the ICU for 14 days is something called chronic critical illness. And a literature review of chronic critical illness will give you about 3 different flavors. The first flavor is a typology that was promoted in 2017 that thinks about weaning failure. So it looks, when do you first attempt to liberate someone from extubation, and how many attempts and how many days does it take, and divides people basically into, it went well, it went not so well, but eventually they get off the tube, or they didn't get off the tube. And in a lot of ways, this brings to mind our classic COPD patients. You may remember Netters, pink puffer and blue bloater. It's a standard way. Increasingly, that very vent weaning has been replaced by Dr. Judy Nelson's 2010 notion of chronic critical illness. And this has been so influential that I want to take a minute and actually step you through some of the text, because I think it's held up 15 years later. They argue the hallmark of chronic critical illness is respiratory fatigue requiring prolonged dependence on mechanical ventilation. Although the term prolonged mechanical ventilation has been used in the literature to describe periods of vent dependence ranging from 2 days to 4 weeks, the period's usually measured in weeks before people start referring to them as chronically critically ill. And let me tell you, 15 years later, the literature still hasn't decided what the right time frame is, and everybody's study uses a different time frame. But 2 weeks is a relatively median estimate. They note that besides the prolonged ventilator dependence, evidence suggests that chronic critical illness is a syndrome with additional features. And these are noted up in the box. Issues around brain dysfunction, issues around neuromuscular weakness, endocrinopathies, malnutrition, anasarca, skin breakdown, and a profound component of symptom distress, and often inability for us to achieve adequate balance between our needs to relieve the patient's symptoms and our desire to have the patient awake and interactive, participating in their care. Third model of chronic critical illness is a endocrinopathy-centric model that Greet Vandenberg proposed in the late 90s that I think doesn't have legs and hasn't been used all that much, but if you're going to do a literature review and you get invited to Kuwait, it seems good to be thorough. So there, I've been thorough. So let's just talk about this in light of our cases. Our first patient, 74-year-old gentleman with ARDS and a prolonged weaning. This is group 3 prolonged weaning. This is a perfect example of a patient who has Nelson chronic critical illness. If that was all this was, this talk wouldn't be very interesting. But instead, I want us to think about this patient. This is the patient who you round in every morning, and when you pick up from the person who was on the night before, you go, all right, what did bed 16 do last night? And every night, bed 16 has done something else that was fascinating and is the reason you're going to start rounding in that room instead of wherever you were planning to room. Because was it prolonged weaning? No. This patient was actually extubated quite quickly. Did they have Nelson chronic critical illness? Their extubation basically precludes them from having the Nelson definition of chronic critical illness. And there was no evidence of endocrine failure. But this patient's definitely stuck in the ICU. So Louise Rose in 2018 proposed this distinction between persistent critical illness and chronic critical illness, and I think it's really useful for thinking about what we're trying to do to guide us. She argues persistent critical illness is reflected by ongoing critical illness and some degree of instability that's no longer directly attributable to their original reason for being in the ICU. In contrast, the concept of chronic critical illness is about relative clinical stability, but continuing to require prolonged ICU stay, usually for prolonged mechanical ventilation, right? Persistent critical illness is another new problem every day. Chronic critical illness is the same problem making no progress. And so over the last decade, we've been interested in the question of how do we define these patients whose reason for being in the ICU is now more related to their ongoing critical illness than their original reason for admission to the ICU. And Dr. Ridley, who you'll be hearing from later, this program basically developed when I spent a year in Melbourne sitting in the cubicle next to Dr. Ridley, one of the best years of my life doing sabbatical. Strongly recommend if you can get your employer to pay for you to spend an entire year in Melbourne doing whatever you want, but not attending any administrative meetings, you should do that. It's really good. It also happened to be generative. So in the conversations with Carol Hodgson, Emma, Ronaldo Baloma, we recognize that there's an empirical component to this. This implies that there ought to be a point in the ICU stay beyond which ICU admission, diagnosis, and severity of illness, the reason they came to the ICU, in the first 24 hours, it no longer differentiates patients with regarding their probability of hospital death. And we were able to put together a piece with Dave Pilcher's Australia, New Zealand ICU Intensive Care Society database that looked at this. The first thing, and got it in the Lancet Respiratory Medicine. That was a good day. The first thing we did was say, let's divide people up into their risk of death on day one. Divided people into the bottom tertile, middle tertile, highest tertile. And what you see is people who had a low probability of death on day one were much less likely to die than people who had a high probability of death. That is not a finding. That just shows me that I know how to calculate probability of death. If that wasn't true, if the left side of this curve didn't show that separation, then the risk model was just wrong, and I shouldn't be talking about this. Instead, the risk model worked. But what surprised us was how quickly these patients converged, and that very quickly, everybody who was stuck in the ICU had about a 50-50 chance of surviving, regardless of who they were when they came in. And so we tried to formalize that by actually saying, let's think of the cluster of things that we think of as acute characteristics, right, that describe you when you come in on day one, that take up your history and physical. And then let's also put in the antecedent characteristics, which honestly, sometimes we ignore in the ICU because we're so focused on physiology. And let's look at how good those are at predicting subsequent mortality in the ICU. On day one, I don't need to know your age if I know your acute physiology score. Acute physiology is incredibly predictive of subsequent mortality with an ROC curve on this vertical axis of 0.9. In contrast, if you just know someone's past medical history, their age and comorbidities, it does a surprisingly good job of deciding predicting who's going to get out of the ICU, but not nearly as good as their acute physiology. But by day 2, day 3, day 4, who they were when they presented becomes less and less relevant, and its information value plummets, such that by day 10, actually it's more important for me to know just their age and a handful of comorbidities than it is for me to know their admission diagnosis and their admission physiology. And while most patients are discharged from the hospital well before day 10, that group who are in there consume an enormous number of patient bed days. So that mere 5% of your patients in Australia who survive to at least day 10 in the ICU take up fully 33% of their bed days. That's part of why these patients are so much of our experience in the ICU, because we don't actually experience patients, we experience patient days, right? Who do we round on each morning that we get to know? But maybe this is Australia. The Australians are incredibly sweet. There's lots of wonderful things about Australia. Maybe it wasn't representative of the rest of the world. So we went and replicated it in England, we replicated it in Canada, we replicated it in Scotland, we replicated it in the VA in the United States. And nearly everywhere we've looked, we've seen a very similar pattern with this crossover happening somewhere between day 7 and day 14, depending on the region, but a very reproducible empirical phenomena. This suggests that there's something going on here, that the ICU experience has a tumultuousness. It also suggests that these patients are incredibly common and account for a huge fraction of our bed days. That's important because that means fixing one of these patients potentially opens up enormous amounts of ICU capacity for you, essentially for free, without needing to care for other folks. So the next question that emerged is, what are the dynamics of organ dysfunction among these persistently critically ill? Is there a particular pattern that we might find? And Dr. Liz Valiante, who was a colleague and mentee of mine, started by asking this very simple question. She picked 50 patients who are in our medical ICU, consecutive patients, and went and read their charts and asked how many of them are stuck on the ventilator the whole time. The literature to date would suggest that if you're in our MICU for 14 days, you're going to be stuck on the ventilator in hypercarbic respiratory failure, where we're trying to figure out what the right strategy is for weaning you from the vent. That wasn't what she found at all. Only 6 of the 50 patients were still on the vent and hypercarbic, but not hypoxemic. Most of the patients, 34 of the 50, had been extubated at least once, sometimes twice, and were still extubated, but were stuck in the ICU for other reasons. There's a group, about a third, who were persistently extubated, who were persistently intubated, and who never developed new organ failures. The folks who were our classic sort of chronic critical illness. But what that means is that nearly 75% of our patients developed new and cascading organ failures, 1, 2, 3, or even 4 organ failures after ICU day 4. And when you think of our mental model, which is often a little bit of set it and forget it, right? We bring people in, we do a really careful diagnostic workup on day 1, we develop an anticipated course, and then we more or less pay attention to people's golden hours on the first day, and we tend to run through, sometimes a little embarrassingly quickly, the older patients. That's not who these are. Instead, we were finding that 70% of these patients developed late onset septic shock. That again, this turns out to be sepsis. So that the people who are stuck in the ICU are not stuck For classic hypercarbic respiratory failure to wean, they're stuck because they keep experiencing new late organ failures, disturbingly often septic shock, with all that implies for their mortality and subsequent outcomes. So can we predict who will develop cascading late organ failures? Liz was an assistant professor, so the first instinct was, can we do this with logistic regression? The answer was no. Can we do it with machine learning? The answer was no. Somebody's going to do it with AI. I don't know whether it's going to work, but what she also said is, maybe we could ask physicians. Actually, attending physicians, one of our key jobs is to be able to see over their horizon, to be able to predict who's going to have problems later on, and to let that prognostication guide our decisions about risks and benefits. This is a complicated slide and some of Liz's work that's under review right now, so I'll ask you not to post it on social media. But the short answer is, in over 2,000 consecutive patients, where every day she surveyed the attending physician and said, do you think this patient's going to be in the ICU for 10 days? And if they are, do you think they're going to develop new shock or new respiratory failure? And it was us. We were garbage at predicting this. The top two lines are for patients on admission. That's fine. Maybe on admission we're not this good. The bottom two lines are for patients who we've already known for 3 days, who we should have a good handle on their physiology. The yellow bar is the fraction of them that did go on to develop late organ failure. And your big take home should be, boy, those yellow bars look about the same size, whether the attending predicted that they would go on to late organ failure or they wouldn't. So obviously this is still work in progress. So let me tell you where I think we are right now. So I think we know that there are many patients who get stuck in the ICU with a cascade of one critical derangement after another. And frankly, enough of your heads have nodded during the last 20 minutes of this conversation that you know some of these patients too, the ones you just can't find homeostasis for. And it's not just hypercapnic failure to wean. Our hypercapnic failure to wean patients are important. They are a real subset, and we need better data desperately on how to use the ventilator, how to balance nutrition, how to balance sedation, how to minimize delirium in order to get them going. But if we only focus on our failure to wean patients as our primary effort for reducing chronic critical illness, we're going to miss most of our patients. Because I fear, I don't know this yet, but I fear that if on day 7 we treat each new derangement as if it were their day 1, we start doing them a disservice. That the things we learn, particularly about septic shock, about early goal-directed therapy, so often in the emergency room setting, just don't apply to the patient who's been in there for 8 days already. And if we go in and fluid load them, or we go in and do all the other interventions that Surviving Sepsis Campaign has shown us save lives in the early scenario, I worry we're doing something wrong for these. And in particular, I think we need to focus more on lighter touch interventions that rebalance them, including how we think about ending resuscitation and how we think about de-resuscitation in a coherent way. I also fear, as a clinician, that we anchor on the presenting complaint, that we round on the 67-year-old man who's post-op day 12 status post-CABG, and somebody whose status post-CABG should do great, and somebody whose status post-cardiac arrest we should be really worried about. And on day 12, those patients are the same patient. There are important specific differences about their injuries, but that this prognostication from anchoring on their chief complaint can actually anchor and bias our decision-making on an ongoing basis that may lead us to assume that the CABG patient's going to do really well and the cardiac arrest patient's going to do really poorly. And then by day 12, that's no longer an evidence-based component.
2 minutes.
And I think we need a new research program about rescuing these patients. So many of you are anesthesia trained, so let me tell you a story about my favorite paper that's a homage to intensivist and anesthesiologist. I'm a medical ICU doc, but a group of surgeons published this, and they got in so much trouble. So they asked, what determines hospitals that have high rates of mortality after surgery versus hospitals that have low rates of mortality after surgery? And the surgeon said the answer has to be the rates of either complications or major complications. And as you can see on the left, hospitals that All hospitals, regardless of their end mortality, had about the same rate of complication. What determined hospitals that saved their patients from hospitals that died after surgery from complications was how good the ICU was at detecting those complications, intervening, and rescuing them. Prevention's important. We all want our surgeons who are careful and don't cause unnecessary complications. But the ICU plays a foundational role in thinking about how to rescue patients when those complications develop and individualizing that. And what I'd like to propose is, as we think about persistent critical illness, we need a research program into rescue that understands for our patients who are already in the ICU, after we've been mucking with them for days on end, how do we find the right balance to go a light touch that doesn't neither under-detects nor over-detects, recognizing that our probabilities are so different than the outpatient setting. Thank you very much.
Thanks.
Thank you, Dr. Jack.
You want to do questions at the end or questions now?
Yes, the question that we would like to welcome Dr. Emma Ridley. She's an associate professor and senior research fellow and NHMRC Emerging Leadership Fellow at Monash University. She is a global figure in the nutrition and critical care with several invited speakership and conferences, more than 95 publications. Welcome, Dr. Emma.
Thank you so much for having me. And it's a privilege to be in this session with many esteemed speakers. So I'm here to give the nutrition intervention perspective on post-ICU syndrome. And I promised Professor Herridge I didn't put this in because you were in the session, but this is a great quote from a book that's edited by Margaret and colleagues. And there's definitely more to life than measuring death, and I think this is what we really have to focus on. And the whole critical care community is now really realising this and moving beyond just hard clinical outcomes, and really that's what it's all about, essentially. So this is the number of nutrition interventions that might prevent post-intensive care syndrome. So it makes my talk a little bit difficult, but we'll see how we go. There's a lack of large-scale RCTs that show benefit with nutrition interventions in critical illness, and there's several reasons that may be the case. So nutrition interventions have been of a short duration, and so it's impossible that we're going to give nutrition for 5 days and expect that we're going to impact long-term nutrition outcomes, long-term patient outcomes. They've been provided early, so they haven't been continued on post that initial critically ill period. And we may be missing the period of most importance to recovery. And it really comes down to when do you need nutrition most. And it's probably not early in large amounts, and it's probably not short term, and we really have to flip our thinking around that. You've all seen this slide, I'm sure, and I'm actually surprised I haven't seen it more times in this conference. Usually it's presented at least 10 times. Maybe I haven't been in those sessions, but this is seminal work by Zudin Puthikari, and it really shows the impact of organ failure and critical illness on muscle wasting. And you can see there's a devastating loss of muscle, particularly over that first 10 days. This has been supported in terms of nutrition interventions by my friend and colleague Leanne Chappell, and this is a beautiful piece of work that was published a couple of years ago now. And really the bottom line, all you need to understand is even if we give patients protein particularly, they're unable to use it, and this may explain the issue with us trying to rehabilitate patients nutritionally early in that period, because they're just not able to use it for muscle protein synthesis. So we've definitely in the less is more era for nutrition, and we were previously in the more is more era, if you're wondering. And it really comes down to the fact that nutrition is not a drug. So as I've said, we're not going to give it and see a change in 24 hours, in 48 hours. That is not how it works. And it's certainly not a fluid. It is a fluid, of course, but it's not just a fluid. And that means it's synergistic. There's going to be multiple things happening at once, and we need to try and think more in a more complex way. It probably all comes down to timing, and so we're now starting to understand that the importance of nutrition may vary across different phases of illness. So in this very early acute phase, and I am talking about days, but it's important to know that days is probably not the best marker, but we do not have anything further to go on in terms of physiological markers. So this early period is when we're really aiming for hypercaloric feeding, so low energy and low protein, followed by an acute late period, which is a later period where perhaps the patients are more stable stable, they might be more receptive to nutrition. And that follows the late rehabilitation or chronic phase. And this is really where we think that nutrition may be most beneficial. This is potentially where we are going to be able to rehabilitate our patients and perhaps improve some of these poor long-term outcomes that we're seeing. And I've just summarised that. So later on in this late rehabilitation phase is where we're trying to optimise nutrition. So first, let's just have a look at the story of nutrition in ICU just to set the scene so we can understand what we're dealing with. And so in intensive care, we know that our patients only ever get around about half of the nutrition that we aim for them to provide. This has not changed over many years. You can look at different papers. This is one that we published with 17,000 patients from around the world. And you can look at other geographical regions and it's the same. Perhaps that doesn't matter in the short term, so the evidence now is showing us that perhaps short term this is fine. It's these long-term patients that we really have to consider that this may be inappropriate for. The story is pretty dire if you eat in ICU. And so this paper looked at patients who were just eating, and half and 94% never received more than 80%. So that would be a metric that we use, 80% of nutrition requirements. But most of them never even got close to that in terms of achieving their energy and protein intake. And immediately post-extubation, also 25% or less of the patients received that metric of around 75%. And so we're really talking about very poor intake. This was from America, this paper, and there's a paper from New Zealand showing again that even though options were available, they were not offered to patients either. So there's some system-based issues as well. As I've said, perhaps this doesn't matter in the short term, but the patient's journey doesn't end in ICU. And I think that's another flip of the switch that we're having now, is we're not just thinking about these patients within the ICU. Their journey continues, and it obviously continues to home. Now, I don't know about where you work, but where I work, the ward is like the Wild West. And if I ever have to go there, I say to my team, if I don't come back, like, send a search party. But you don't know what's going on there. You can never find a doctor. No one will talk to you. And so I think we really have to try and address some of these system-based issues, particularly for our patients that have been critically ill. And we know, all jokes aside, we know our patients describe that as a very scary time, that transition to the ward. They go from this very closed environment, very close monitoring, one-to-one nursing, to being in this large environment, and it's quite challenging for them. What is the story of nutrition in that post-ICU period? Well, we know that patients spend longer on the ward than they do in ICU, but we also know that we intervene the least and they do worse, especially with oral nutrition alone. So in an early piece of work, we looked at this and we showed that if patients were eating with no other nutrition support, about 37 to nearly 50% of energy and protein intake. They did better if we provided them with nutrition supplements, so they got up to about 70% of their nutrition intake, and they did best when we continued enteral nutrition with oral intake. And so it just shows that there's a whole spectrum of nutrition provision depending on the mode that you have. Again, Leanne showed that intake was worse in the recovery phase and the deficit was greater with patients receiving oral nutrition alone. So these were two pieces that were quite early on in the literature. We now have several pieces that are supporting this, so we know we have a problem. And then interestingly, dietitians were spending just 20% of their time in this post-ICU period, when really now we're thinking this is the period where we should be spending most of our time. We really have a service issue here in terms of redirecting our resources. Leslie Mosey from Canada also looked at this, so a small sample of 19 patients, but studied over 125 days, so a very long time. And again, showed that this is a very poor intake and oral nutrition as a sole source, patients did very poorly. Why is this happening? Well, we've summarised this. I guess this is an opinion piece, so whether you agree or not, but we have summarised this to be patient factors. So that's things like issues with eating, which is associated with critical illness, like poor appetite, early satiety, fatigue, nausea, how they feel about their body and nutrition. There's some really beautiful reports around how patients feel their body is letting them down post-critical illness. They feel embarrassed about asking for help with nutrition. If they can't feed themselves, previously they might have been independent, they don't want to ask for help. So all of these things are impacting our patients, and we need to be acutely aware of that. There's clinician opinions, so how interested you are in nutrition, what level of education you have around nutrition, if you have any. We know that medical education, nursing education doesn't have a lot of nutrition education within it. And then there's system-based issues, as I've touched on, food service type problems, resource problems, not directing our systems in the right way. We've also looked at this out to rehabilitation, so this is one of the first and only reports as small data again, but there's very limited data. We showed that oral nutrition was the most common mode in the ICU for this group of patients who were probably not as sick as a normal group, but also in rehabilitation, oral nutrition was the most common mode, and we see that on the ward. So this is where a lot of our work has to be. It has to be with the patients that are eating, because this is mostly what is happening. We also looked at nutrition impacting symptoms across different aspects. So we've got ICU, acute ward and rehabilitation, and altered conscious state followed by loss of appetite, dysphagia, nausea, were all of the most common nutrition impacting symptoms. And so these are things that we're going to have to develop some strategies to help our patients with. We looked at this on a larger scale just recently, so I guess those pieces that I showed you were single centre, smaller pieces, and they were from many years ago. So unfortunately during COVID, it wasn't planned to be during COVID, but it was, we got a group of hospitals, so 44 hospitals together, and tried to really understand some more of these characteristics with a focus on patients who just were eating, because not many people have focused on that, and ended up with 409 patients. What we showed was that these patients who were just eating were less sick, less unwell. Obviously, that's probably the case. And we also showed that they had lower rates of nutrition assessment, lower prescription of nutrition supplements. They only received about 700 kcals per day and 40 grams of protein over their admission, compared to those that were receiving enteral nutrition, where they got around 1,200 calories and up to 60 grams of protein. And the other thing we highlighted was these system issues, so quantification of nutrition was not often attempted, and where it wasn't done. And so this is a major issue. How can we talk about the value of nutrition if we can't even assess how much our patients are receiving? Just to highlight a basic nutrition principle, so if you want to lose weight, a half a kilo to 1 kilo per week, you need a deficit of 500 to 1,000 calories per day. And that is exactly what we have our patients on in terms of deficit. So we're talking about rehabilitating these patients, but we're giving them a nutrition deficit that is inducing weight loss, on top of all of the other issues around critical illness that induces loss of muscle mass. And so there is an issue here, and we need to come up with strategies. Whether we can prevent that weight loss, that's another thing, but I don't think we should be on top of all of the other things giving them a deficit to induce weight loss. We also looked at the patients that transitioned from enteral and parenteral nutrition, what happened when they went to oral nutrition, and acknowledging this is very simple observational data, and there's a few patients in this group here because this is just what happened in clinical practice, so we just took the data if it was available. But you can see they drop off a cliff. So they go from not being too bad in their nutrition to they never recover once they start eating orally, and that really highlights the issues that we have. So if we think that the rehabilitation phase is the most important phase for intervention, we really need to focus on that. The late period, mostly oral nutrition, and it really comes down to who is the most vulnerable in terms of our nutrition thinking. We have spent so much time focusing on mechanically ventilated patients, and that's okay because we didn't have much data. We didn't know what we were doing with those patients. We've now established that in that first 5 to 7 days, trophic, enteral, and parenteral energy and protein delivery is fine. But what happens after that, and what happens to those patients that eat orally? There's a whole gap here around what we're doing, and so we really need to be mindful of that. So we're trying to address this. So we have a grant looking at nutrition care, so both mechanically ventilated and patients who receive oral nutrition alone. And we're trying to have a really broad brush and a overview of this. So we're doing a whole dedicated piece. We're about halfway through this process of a 5-year grant, looking at the consumer experience of nutrition, so what patients, families and clinicians want out of nutrition care, because surprise, surprise, not many people have asked patients and families what they want. We're looking at the clinical data, so what is happening in practice, And then we're going to use a co-design process to bring those two things together to develop a new model of care, which we'll test in further research in the end. So we're about halfway through that, so I hope to be able to come back and talk to you about that process. So let's just have a look at some potential interventions. I've told you there's none, because there's none that have been successful, but people have tried, so let's just talk about that. So one of the things that was put forward that might be successful is bolus delivery of enteral nutrition, with the thinking that if you make nutrition more physiological, we don't eat continuously like we feed our patients in ICU. We have meals, so if you bolus nutrition, perhaps that will increase muscle protein synthesis. It was a really good idea, nice concept. They also used an outcome that was muscle-based, which I really enjoy, but they didn't show any difference. And maybe that comes back to Leanne's work that I've showed previously. This was published prior to that, where even if you give it to our patients, they can't utilise it for muscle protein synthesis. The second thing is HMB, which is an amino acid, a conditionally essential amino acid. It has, outside of critical care, had good results in terms of enhancing muscle capacity, particularly for elderly patients. And so it would make sense that perhaps we translate that to critical care. In this meta-analysis, it did show a signal that perhaps that might be something that would be of benefit, but no RCTs have actually shown that to date. And so it's another intervention that unfortunately not going to be the case. What about extended nutrition interventions? So outside of critical care, long-term nutrition intervention has been shown to improve outcome. So this is a large study of 2,000 patients, very nice study published in The Lancet of not critically ill patients, so medical inpatients at nutrition risk. They compared no nutrition intervention, so just standard hospital food, to an enhanced nutrition intervention, and showed with a composite outcome it was favourable in terms of the intervention. So we looked at this and thought, well, what about if we applied this to critical care nutrition? So we developed a study called INTENT, which was the first long-term nutrition intervention for critical care for critically ill patients. Our aim was to test the feasibility of this intervention, keeping in mind that long-term nutrition interventions are complex and hard, so we wanted to see whether we were able to get separation in this. And we hypothesised that we would be able to get a difference of at least 215 kcals per kilo. We got a difference of around 271 kcals per kilo when it was adjusted. And if you think, oh, that's not that much, well, think the duration of this intervention was 19 days as a median. So it is a long nutrition intervention. It's the longest that we've seen. And over 19 days, that's a significant additional amount of energy for these patients. And in terms of protein, we've got 20 grams per day. It equates around 340 grams in total of additional protein over 19 days. We did not see any differences in secondary outcomes, slightly disappointing, but we were not powered for that, so I can't be disappointed, but it would be nice to see something. We also planned to do something called Intent Muscle, which I was very excited about. And what we were going to do was measure changes in muscle health, muscle function associated with the intervention and the usual care group. This has never been done before longitudinally. We were going to do it over an extensive period of time to see how our intervention may have impacted these measures. But unfortunately, due to COVID, we could only do a very small number of patients, so this will now turn into a feasibility study, and we won't be able to really draw the conclusions that we wanted to previously. This study so we have a published protocol. The study has just been published this year in Critical Care, and so if you'd like to read more details, it's available there. I don't have time to go through everything today. And probably what I would like to finally say is the missing piece, rehabilitation. And so this is something that obviously it probably doesn't make sense to rehabilitate our patients nutritionally if we're not getting them up and moving. And there's a couple of studies that are ongoing, and actually I had a little look yesterday and it seems like there's been quite a few more pop up. So I think watch this space. The Nexus trial has been recruiting for quite some time, and I'm not sure exactly where it's at. I did hear that they were still trying to recruit, but I'm not sure. But that was something that we would really hope to be able to see the results of soon. There's also another study in Switzerland that is recruiting from a group who do a lot of nutrition research. So they're obviously trying to combine that intervention. And then a trial called Improve, which I've not heard of before, but focuses on a nutrition and rehabilitation intervention as well. And then I think my last point would be, can we learn from high-performance sport? I think there is a lot of potential in terms of interventions that sport and athletes use. Whether or not that's going to translate, I mean, I've showed you many examples of things we've tried to translate into critical care. The physiology, the changes that occur perhaps are not going to be able to be overcome by some of these things, but it's definitely something that we should think about. And so I'll just leave you with, there is more to life than measuring death. And again, I think this is a great quote. Unfortunately, I have to speak in another track now, so I can't stay for questions. But if you have questions for me, I'll be around till the end of the day. So please just come up and ask if you have any questions. Thank you.
Dr. Sean Devlin. Dr. Sean Devlin is a pharmacist and critical care specialist, past president in the American Delirium Society, the antipsychotic therapy in delirium. Welcome to Doctor.
Thank you very much. It's a real privilege to be part of this panel and speak to you today. I think one thing I should have put in this title is a big question mark, right? With antipsychotic therapy, are we paving the way for better outcomes? How many people routinely administer antipsychotics for their patients with delirium in the ICU? Just show of hands. Okay. Yeah, let's say regularly. That's a better word. Okay, yeah. So, okay, a few hands go up. So, yes. These are my disclosures. So obviously we know ICU delirium is prevalent, depending on obviously the predisposing and risk factors. Severity of illness is a key driver. It's certainly associated with substantial distress to patients, families, and caregivers. I think this sometimes gets lost a little bit in the ICU where we're ranting outside. We see a positive CAM ICU. We might talk about that. But sometimes we're not always thinking about what is that patient's symptomatology. I'll just throw that out. We'll talk a little bit about agitation. Just because someone is CAM ICU positive doesn't mean that delirium's the sole source of their agitation. Obviously, an important relationship with short and long-term mortality, although this isn't necessarily a causal relationship. So that's another thing to mention. Certainly, it can prolong mechanical ventilation and length of stay, and certainly lots of great data suggests, important data suggesting long-term cognitive decline and dementia, particularly in our older adults. And everybody's certainly seen the brain ICU data from Vanderbilt. And I think one of the most important things that maybe drives us to use pharmacological interventions to treat delirium besides agitation is if we could shorten delirium, could we potentially reduce the the incidence of long-term cognitive decline? Again, this is an association, it's not a causal relationship. Well, there's many, many medication classes that we've, thought about over the years as treatments for delirium. Certainly GABA agonists, alpha-2 agonists, melatonin agonists, NMDA antagonists like ketamine, cholinergic enhancers like the anticholinesterase inhibitors, and then what I'm going to be focusing on today is antipsychotics. Really important, though, that we don't get too caught up on looking at pharmacology and receptors and neurotransmitter theories of delirium, thinking that, well, this drug probably might work. We need rigorous controlled studies. All of these drugs have important safety concerns, particularly in older adults, and particularly when these drugs continue to the floor and to the outpatient setting. And some of these patients, many patients, leave the hospital on antipsychotics for weeks or months. It's a really big problem with polypharmacy and our inability to deprescribe. And I think it's important, I'm not going to present the study, but Arjen Sluiter's group published a study in the mid-2000s where they did a randomized control study with rivastigmine to treat delirium. And the study was stopped earlier. There was an important increased mortality signal, and it actually the study was not reducing delirium. Certainly, though, going back, we know that if you believe the neurotransmitter theory of delirium, and certainly our our knowledge of how delirium evolves it's far more complex than a neurotransmitter-related disease. Neuroinflammation, I mean, it's a complex, multifaceted mechanistic pathway. But you certainly could see that, hey, maybe antipsychotics might be able to affect these drugs. The drugs we probably turn to most frequently are haloperidol, quetiapine, risperidone, and olanzapine. These drugs all have very different pharmacology, and they work on different receptors. Although, you know, obviously there's much more data in the psychiatric literature in patients with you know, major schizophrenia or other psychiatric diseases. The relevance of this different pharmacology in delirium and what we're doing in the ICU is really been not well evaluated, nor has the dose response of these drugs. I think it's also important to know the history of antipsychotics. So when I started working in the ICUs in the early 90s, I mean, patients would have ICU psychosis, right? And we would start haloperidol infusions, realizing maybe we should be checking a 12-lead EKG. And the data to support this was really just small case series. You know, there's a small case series by Rich Riker that published in Chest where they actually found that patients were calmer. That's not rigorous data, but you know, the 2022 first pain, sedation, delirium guidelines made a recommendation. Haloperidol is a preferred agent for the treatment of delirium in critically ill patients. The clinical practice guidelines that I was part of in 2013, a little bit more rigorous using the GRADE approach, you know, made the recommendation there's no published evidence that treatment of haloperidol reduces the duration of delirium, but it doesn't really come out and say, maybe we shouldn't be using it at all. And then in these guidelines, when asked about atypical antipsychotics, they make a recommendation that atypical antipsychotics may reduce the duration of delirium in adult ICU patients. And this is all based on this very flawed rinky-dink study that I published in 2010. And this was meant to be a feasibility study. No one had ever done a randomized control study of an antipsychotic for delirium, and there's all kinds of feasibility outcomes. I'll tell you kind of the real story is to get this published, Critical Care Medicine wasn't particularly interested in the feasibility outcomes. They really wanted the clinical outcomes. We only had 18 patients in each group. We were so underpowered. Just by chance, we happened to see a faster duration of delirium, faster resolution of delirium. But, you know, everybody in both groups were getting as-needed haloperidol. Our IRB at the time said there's no way you can have a true placebo group because haloperidol is the standard of practice. So this is a highly flawed study. And honest to goodness, I have spent the last 15 years telling people, don't use quetiapine regularly for delirium. You know, it might be an option if someone's agitated, not from another cause, but it's gotten in the drinking water. Thank goodness with the PAD guidelines in 2018, we did have a little more evidence, although some of the biggest studies still weren't available, but we were much more rigorous and made the recommendation we do not suggest routinely using haloperidol or atypical antipsychotics to treat delirium, and really talking about, you know, more symptomatic treatment potentially, and then as a potential, you know, treatment for agitation. But despite these guideline recommendations, this is data from Vanderbilt, you know, antipsychotic use is prevalent. So when Vanderbilt looked at, you know, more than 28,000 ICU admissions, of which about 40% had delirium, 50%, 4,000 of these patients were getting antipsychotics. And they weren't just getting one antipsychotic. Most of these patients were getting multiple antipsychotics, you know, and that's not unheard of. I certainly see it in my practice. And what they did when they did a regression analysis is they actually found that none of the antipsychotics were associated with a reduced risk of next day delirium. So it was a daily model. And when they looked at mortality, both risperidone and haloperidol were associated with greater mortality, potentially a reduction in mortality with quetiapine, but that's obviously just hypothesis generating. This is just a quick summary of some of the larger randomized control studies that have been published since my rinky-dink quetiapine study. In the HOPE ICU study was published by Tim Gerard, found no difference in delirium, duration, any other outcome, and certainly not 30-day or 90-day mortality. A Scandinavian study by Anderson Ramberg was another haloperidol study, AIDS ICU. No difference in days without delirium in the ICU or any other relevant outcome. But they did find about a 7% absolute reduction in 1-year mortality. I'm going to talk about that in a second. I think it's hypothesis generating, but it shouldn't be a reason that we institute haloperidol for 1-year survival. I was involved in a Dutch study by Lisa Smit. We focused a little bit more on symptoms and sequelae of delirium and did find that there was fewer benzodiazepine use, less sedation, and fewer restraints, and less patients fell out of bed. So maybe it does have a role for symptomatic treatment, but no difference in other outcomes. This is a recent meta-analysis by a Canadian group, and basically when they look at all these studies, virtually no difference in delirium-free days, duration of mechanical ventilation, hospital length of stay, or mortality at longest follow-up. So this is pretty negative data in terms of any justification for routine or regular use of antipsychotics. What about long-term outcomes? This was recently published. This is long-term data from the HOPE ICU study by Tim Gerard's group, and virtually no different in long-term cognition, quality of life, functionality, or mortality. So let's just talk a little bit more about the 1-year survival curve. It's interesting data, and basically this is the Kaplan-Meier curve, and significance was reached pretty much at the time of ICU discharge and persisted across up to the 1-year period, obviously realizing people would drop off if they died later. I worked with Tim Gerard to publish an accompanying editorial because the key thing in the study is there was virtually no difference in days spent without delirium or coma. So what's the mechanism here? And we hypothesized, maybe it's delirium severity. This is something that we're really not measuring yet routinely in studies, but I think it's extremely important. They looked at whether patients got sedatives, yes or no, but they didn't collect data on the amount of sedatives per day and the mix of sedatives and opioids, et cetera. Does haloperidol reduce dysfunction of other organs? Haloperidol is a potent anti-inflammatory agent, so maybe there's some mechanisms here we're not sure of. Does haloperidol improve PICS or post-ICU frailty? I mean, this is all just very much hypothesis generating. And then I worked with one of my grad students using Mark Van Borgaard's REDUCE study, and we actually modeled and found that the greater the amount of haloperidol you gave to treat delirium was associated with the survival benefits. So this was published a couple of years ago in Critical Care Medicine. So there's definitely some interesting things about dose, mortality, and this interrelationship that I think we want to pursue, but this isn't a reason to increase your use of antipsychotics. So how should we approach delirium management in the ICU patients? Well, I think the most important thing is to screen it regularly and reliably, look for symptoms, ask the patients if they're having hallucinations or fear. Think about anxiety too, because that often is part of this. Think about the risk factors. So this is getting back to, Wes Ely talked about yesterday, Dr. Dre. What are some new things or new conditions? Is the patient going into sepsis? Remember, severity of illness, organ failure is a big risk factor for delirium. So what's happening with the patient? What can we do? Remove and reduce medications, right? We have a long list of medications, benzodiazepines, opioids. If the patient's on high-dose corticosteroids, can we reduce the dose? A lot of these medications, have a risk for delirium, and it's all dose-related. Certainly, we should be rigorously using the A to F bundle. That's certainly the kind of the gold standard way, but where we're seeing reductions in delirium is with mobilization, sleep improvement. It's all the non-pharmacologic things. It's not pharmacologic therapy where we're really seeing reductions in delirium. And we certainly know when we rigorously use the ADEF bundle that we're going to reduce delirium by about 40%. And even if we just partially use it in a dose-related fashion, we're going to see reductions in delirium. What about agitation? This is a really big thing. People just jump to agitation. They want to give a sedative. It's really important when you have a patient that's agitated. Obviously, you might need to give a drug if it's dangerous agitation, but you need to go through a list of things that could be causing the patient's agitation. Delirium is just one thing, and I don't know if we do a good job routinely in the ICU doing this. Sometimes we'll just, crank up the dose of the propofol or order an antipsychotic. I think delirium's really hard to study, and there's a lot of phenotypical data looking at different types and causes of delirium in terms of long-term cognitive impairment. Some of this is starting to play out, but in terms of response to drug, people have not looked at phenotypical subgroups of patients in terms of the response to therapy. That's never built into trials. There's lots of patients that we really struggle with delirium assessment, right? Our neurocritically injured patients, patients with reduced level of cognition, and cognition certainly with dementia, but I mean with sedation. We don't really have a great validated biomarker. Certainly, as Wes mentioned yesterday, there's evolving data looking at EEG, which is a great biomarker, but we don't really have a blood marker that we can draw like troponin or anything to say, well, this patient might have more brain inflammation and maybe it's going to get delirium. The baseline risk factors really vary there's a huge amount of heterogeneity between patients. The onset of delirium, most people that are critically ill are going to have delirium at home or where they call EMS and come to the ED. But we're first often detecting it in the ICU, sometimes a day or two later. And this is a big barrier for trials because then we have to get consent and try to randomize patient. Even if we have sort of rapid consent or inferred consent, we're not starting these interventions sometimes for a couple days after the patient's had delirium. The symptoms, we don't know what symptoms of delirium really need treatment, right? We haven't explored that at all. Delirium persists, but often, studies end in the ICU or at the hospital. What about all these patients in LTACs and rehab or even at home that maybe have persistent delirium, but often comes back? And then what are the long-term outcomes that are really important? Certainly I would argue long-term cognitive decline is, but there's lots of other PICS-related outcomes that we need to explore. So in closing, this just came out. I worked with a large group of global delirium investigators through the NIDIS, NIH-funded NIDIS group, to really focus on recommendations to advance future studies where we're looking at treatment of delirium, both pharmacologic and non-pharmacologic. And we make a number of important recommendations to sort of build on some of the challenges I just talked about. But at the end of the day, hopefully I've convinced you, think about that when you have a patient with delirium, think about an approach that maybe antipsychotics are at the end of your armamentarium, and think about if you do decide to initiate an antipsychotic, why are you using it? And if the patient doesn't respond, whether you're using it as a sedative or for symptoms, think about stopping it early so we can reduce antipsychotics until we get much more rigorous data to support regular or routine use. Thank you very much.
Thank you, Doctor. Our next speaker will be Professor Margaret Herridge. She is a professor in the Department of Medicine and a senior scientist in the Toronto General Hospital and Research Institute. Welcome, Prof. Margaret.
Thank you very much, and thanks so much to Abdul Rahman and the organizers for the privilege of being part of this really wonderful meeting. Thank you so much. So I'm going to talk today for the next few minutes on Beyond Acute Care, the perspective of patients and families. And I don't have any conflicts, and I have no relationship with pharma or industry. Our research work is funded by peer-reviewed funds from the Canadian Institutes of Health Research. I'm going to talk really just to contextualize very briefly on PICS, extended PICS, some de-adoption issues during COVID that I'd like to highlight. But I really wanted to focus today on care transitions, which some of our speakers have already addressed, because these are very patient-centered outcomes, the concept of the ICU care continuum, and interprofessional post-ICU follow-up. So Ellie Azoulay and I had the honor of writing a review on outcomes after ICU, and just to highlight a few things, in addition to this really being a continuum, is that it is important to recognize that there's acquired or exacerbated injury in the ICU, and there is a lot of iatrogenesis going on. And I think it's important for us to really have a hard look at this and how we de-adopted best practice during COVID in particular and caused a lot of harm. And also how all of this impacts the caregiver, the substitute decision maker, children, parents, everyone. And this completely disrupts the family unit, and important to think about that. And just to highlight here some of the complex care transitions, increased healthcare use, and cost, the financial stress, even in a single payer system like we have in Canada, job loss, and really a lot of challenges returning to work. This is a patient in one of our cohort studies, our Recover cohort, as sick as you can get, and I'll show you her later, but on ECLS, pressors, renal replacement therapy, vented, etc. So this is not a talk about PICS, but just to contextualize a lot of background literature leading to this seminal publication led by Dale Needham with a really wonderful interprofessional stakeholder group, and really outlining some of the main domains of post-intensive care syndrome in terms of mental health, cognitive health, and physical impairments. And the extension of this by Anne-Françoise Rousseau and Jean-Charles Prisset in 2021, really highlighting the message, and this is a message I was trying to convey in an earlier talk, that this definition should be in evolution. It should be thought of as a dynamic definition. It's not static. As we learn more and more about the sequelae of chronic, of acute illness, acute critical illness, and chronic critical illness. So I also highlighted some early work by Richard Griffiths and Christina Jones in an earlier talk, just to tell people who they are and help people to understand a lot of the pioneers who have come before many of us who've worked in this area. And here's some quotations from Christina's follow-up clinic. That the patients reported that they are very panicky. A lot of these patients have agoraphobia. They've lost their self-confidence. They have chronic anxiety disorders. They're angry with themselves because they're not getting better quickly. There's enormous frustration. They've got weakness that is beyond description, that people are pulling themselves up and down stairs. They cannot swallow. This relates to Emma's wonderful talk, a lot of dysphagia problems that are very, very morbid. And people afraid to go to sleep, afraid of revisiting some of the nightmares they had in ICU. So it's a really enormous life disruption. And I really love quoting this paper and highlighting it at meetings because wow, COVID was a real lesson in our ability to completely de-adopt 2 decades of work that showed how the A to F bundle really improved patient outcomes, and how quickly we de-adopted this, and how much harm we have done by this, and how hard it is to re-adopt when the culture seems to have disintegrated, and the cultural memory. So many people have left our profession now in nursing, a lot of the interprofessional team, that there isn't this institutional memory about how potent these interventions are and how difficult it is to re-adopt. And you can see here pretty stunning de-adoption, and you see the family weren't there. And we've already talked about that and how important it is that the family come as a non-pharmacologic intervention for delirium. So I'm going to talk briefly about trajectories here, and this is a really wonderful paper by Mark Unruh and Chris Cox, who've done a lot of seminal work in this area. And this slide isn't intended for you to see all the small detail. It's really intended to message how chaotic and Byzantine and disorganized all of these care transitions are for patients after critical illness. They leave the unit, they go to the floor, they come back to the unit, they go to the ward, they go to rehab, they come to emerge, they come back to the unit. And they are engaged in this cycle, basically messaging that they have exhausted their resilience and they are unable to get better and to move forward often. There's a recent review on care transitions in critical care clinics that I highlight for you. This is a really wonderful interprofessional document, and highlighting again some of these major care transitions, and our previous speakers have done this as well. I just wanted to highlight a few quotations to highlight some of the patient and family perceptions. Leaving the ICU, after I left the ICU and noticed the nurse ratios to the patients had dropped, I thought to myself, wait a minute, why isn't she looking after me? So this feeling of sort of abandonment, anxiety. Leaving the hospital, if we could just speak to someone who'd had a similar experience, would have helped a lot. To just sort of validate that this was a shared experience, these were shared challenges, issues, anxieties, concerns. And returning to primary care, the transition period after I left the hospital, before I was able to go into rehab after transition, the hardest period was really finding some connectedness in the community, just to paraphrase, and finding someone basically to look after me. So this group adopted the Timing It Right framework, which actually was developed by my co-principal investigator in our Recover program, Jill Cameron, just to give Jill some profile here. And she's a rehab scientist in Toronto, PhD rehab scientist in Toronto, who's really studying this and developed this framework in stroke patients. But really it's helping to ground and create a framework for how difficult care transitions are, and to really try to understand how to meet those care transitions through educational interventions. And you can see here they've sort of created another schema where people move from ICU into late community adjustment. And the challenges are different. And we tried to message this in our paper to really think about beyond the ICU now, at least to a year, but I was trying to emphasize in an earlier talk that challenges can go on for many, many years. And I think COVID may be a great example of needing to move even beyond 5 years to really understand what happened to patients, families, and also some of the very late sequelae of this very generalized and profound endotheliopathy. Okay, so what about families? This is Huynh Hare, who's in this picture now. This is 2 years later. This is her husband and her twin daughters. They've given me permission to use their names in pictures here. Huynh had a difficult journey, but she was 35 when she got sick and had a very good recovery, but not without a year of rehab, mental health challenges, and a lot of difficulties returning to work. And just to highlight the Pix family, and we know the family gets sick with very severe mood disorders, often often progressing to true psychiatric illness, complicated grief reactions, adoption of new substance misuse problems in a maladaptive way, a lot of shame associated with this and difficulties. And this is some quotations now from families. And these are from a really lovely paper by Chris Cox. Here I've listed a number of references. That the families are really experiencing a lot of distress from fluctuation in mental status and cognition, the distress from delirium, how terrible it is to see your loved one transformed in the ICU, apologizing to staff for behaviors people have never seen, feeling that the staff actually disbelieve them, which is another terrible thing. Lack of support, difficult in actually explaining, educating, feeling of physical distancing and emotional distancing from the critically ill patient, and overwhelmingly some lingering feelings of regret, and articulating over and over, and we've certainly heard this in our own follow-up program, that the family life, the individual's life has really been changed forever. These are very robust and potent things. So what can we really do about this? And I just wanted to emphasize two themes because there's not so much time here. One theme is that the patients want us to listen to them and their families. They want to be heard. And I just sort of, maybe I'm a bit jet lagged, but many of us knew Randy Curtis, and he's an exceptional person. Anyway, I'm sort of unexpectedly emotional just talking about this. But anyway, Randy came up with this schema called the value, sort of guideline, value strategy, where you're really trying to spend time and value what the patient says. Maybe this is self-evident, but we don't do this well enough in the unit, to really acknowledge people's emotions, to actively listen, and to really try to understand what the patient was as a person. Wes talked about this yesterday. And to elicit questions from the families. And the patients and families, as I say, want to be heard. And Randy really contributed so much seminal work to our community, but he was such an amazing role model and educator in this way to listen and not to talk constantly and be giving information constantly. And one of Randy's mentees, Doug White in Pittsburgh, another wonderful colleague of ours, many of us are very friendly with Doug, really devised this important family support intervention, which really enhanced the quality of communication. And families and patients really responded to this. And although this did not seem to affect the burden of psychological symptoms, interestingly, this seemed to really decrease the ICU length of stay. And because of that, and the cost associated was really taken up and funded by the hospital because they perceived this to be cost savings. And in other work, Doug's group was also able to show that in most clinician family conferences about goals of care, often there was a very minimal time spent on communication about values and preferences. So really very important to emphasize that and how important that is and how helpful it is for patients and families to feel heard and feel validated. And Ellie Azoulay, Nancy Kentish-Barnes, so many others, Frederick Pouchard, have written about this, and Ellie put this graph together, really again extending the construct of the continuum and how some of the challenges in the unit really do have long-lasting ramifications. So how do we care for patients and families just in the last few minutes here? This is a family who's part of our Canadian National COVID follow-up study that the ICU cohort I'm leading currently with a group of national colleagues. And Ashley and her husband, Kirk, and their son Clayton could tell you all about a pretty terrible life experience that they shared and how difficult it was to get better. And she, like Wynn, had lots of challenges, neurocognitive challenges, functional challenges, psychiatric challenges. So how can we really look after our patients and families? Well, I already said I think people really want to be heard, and they want to be in touch, but how else? There's been a lot of discussion at this meeting about the A to F bundle. People want us to really be rigorous in our care for them and evidence-based. And I just wanted to highlight two recent early mobility studies, one by Carol Hodgson, the other by my Canadian colleague and friend, Michelle Coe, member of the Canadian Critical Care Trials Group, to just show the studies had different signals in terms of some concerns about harm, but so important to get people moving, and as already mentioned, how potent and multidimensional the benefits can be. And in this beautiful paper by Bhakti Patel from the University of Chicago, really see how potent the early mobility intervention was in terms of cognitive health at 1 year. So really so important to observe these things. And just to also pay homage a bit to Christina Jones, and the innovation of the ICU diary, which again, in terms of communication or acknowledgement, a debrief on what actually happened to patients and families in the ICU when the patients really are amnestic for this, and the family's so overwhelmed, the information is so distorted or often really not remembered as a coping strategy. And I'm just going to allude to this, but Emma gave a fantastic talk on this, and really just understanding the importance of the microbiome, dysbiosis, and really how to feed people across the continuum of critical care. And in addition to the patients and families wanting to be heard, is really this overwhelming desire to be followed. And having done ICU outcomes work for a while, this is one of the most robust themes. People want you to educate them because they actually want an ongoing opportunity to debrief about what may be the worst thing that's ever happened to them or their family in their lifetime. That is absolutely true. And very difficult to recover from, and the first phase is really understanding, debriefing, discussing, normalizing a very abnormal event, that they are not alone. This isn't a solitary experience. It's a shared experience which provides people with a lot of comfort. People want continuity of care. They absolutely do. And they want to know you. I personally felt kind of uncomfortable about that initially. Not that we have to have really personal relationships with our families, but they wanted to know why you became an ICU doctor. Why do you do this crazy work? And people honestly wanting to tell you how much they appreciate how hard the work is and the contribution you made to their life and the life of their family. And they're looking to us for advocacy. So this is one of the challenges without standardized ICU follow-up programs, is there isn't really an educated group who's connected who can advocate. But if you're in an ICU clinic and they're intensivists or interprofessional people who actually understand the ICU, maybe have connectedness in the hospital, you can leverage your connections, your network, to really make very potent, or to be a very potent advocate for patients and families. And they are looking to us for advocacy, because a lot of people just simply do not understand how horrible this was. And because we work there, we are there, we understand. And that is enormously validating. So I just list a few programs here. There's so many programs, which is fantastic, internationally even more fantastic. And most of the programs really follow a pretty standard format. And that standard format is that they are focused on multiple organ systems. They are interprofessional. They are longitudinal. It helps that they're in person, but they don't have to be. And they're really spending time. And if you do this work, you know that a patient will want to talk to you all day long if you have all day long. But they really definitely want to debrief, and helpful to have an approach that is very multi-system, because of course as intensivists we are geared to multi-system dysfunction. And I think a lot of the tenets of critical care and our approach to problems, bringing those, that multi-professional work environment, that focus on multi-system disease, that's a very, very helpful focus to bring into the follow-up clinic environment, and to the understanding of how this post-intensive care syndrome or multidimensional disability construct needs to continue to evolve as we deal with more and more complex critical illnesses and deal with pandemics or epidemics. So just some final thoughts. I didn't talk about aging today. I probably talk about it this afternoon. For those of you who have the, I don't know, durability, or I don't know, to stay to the end of the day. But anyway, age matters a lot. I'm going to talk about that later on. But there's a lot of changes now with who is ending up with some of these challenges who need to be followed. And whoops, that's mine. Okay. And also some of the uptake of technology and some of the consequences of using ECLS, some advanced technology, which definitely has its own challenges. De-adoption of best practice, which I hope I have emphasized, has really caused a lot of harm. And the need to evolve this definition, to have post-ICU follow-up for patients and families because they want it, to acknowledge disability, to educate, to optimize outcomes, to facilitate consultation, to be great advocates, and to be mindful of mitigating iatrogenesis in the ICU and to readopt what we've de-adopted. And overall, I hope to, with our other speakers here today, and a pleasure to speak in this group, and a privilege to embrace really the construct of an ICU care continuum and the need for ongoing interprofessional care. And with that, sincere thanks and mille merci from Canada.
Now I would like to welcome our speakers to the stage for questions and answers. Dr. Adil.
Thank you very much for these very interesting thoughts. A question and comment for Dr. Margaret Heritage. So I guess one of the, probably I spoke about this yesterday in a different track and will reintroduce this idea again. I see how much emphasis you guys put on family and family presence in the ICU to prevent delirium as part of a family journey with the person being sick in the ICU. Unfortunately, in this part of the world, most of our ICUs, at least in this country, if you want to visit your loved one, you'll be looking at them from outside of the door. You are not allowed to go in. And I think it's time for all of us in this room to change the practice. We started doing this in our hospital from 8 in the morning until 7 in the evening, and we have no issues with families. I think so many barriers, so many excuses have been put through to say, let's get them off. And I think that's the most disservice we do to our patient. So your thought on this. So that's number one. And then number two, if you are in this part of the world where you're going to start your post-ICU clinic, who would you choose in terms of patient that you will follow on? Would you choose everyone, or you just handpick some of these patients? Yeah. Thank you.
Well, thanks for that question. And maybe I'll answer the first part and then maybe invite my colleagues here to comment a little bit on the second part. Maybe Jack can comment on the second part. Well, just, I mean, I don't know how else to say it, maybe shortly. I mean, I agree with you. The families are just such a fundamental part of who we are. And it does seem very counterintuitive, but I think I've hopefully shown you damaging to separate us from our loved ones. It doesn't make any sense. I think that people historically felt that sort of families are in the way, or they're going to obstruct care, or they're going to collapse at the bedside. They're going to complicate everything, make everyone all upset. But in fact, sometimes that does happen, quite honestly, so I don't want to negate that completely, but most of the time it doesn't. And, you know, John mentioned in his talk that, I mean, having family or like family presence or these non-pharmacologic interventions is better than any drug you can give a patient. To have a loved one there holding your hand, reorienting you, is one of the most powerful things. And I think when there's another pandemic, because sadly there will be, we need to learn from what we just went through, which is we cannot be separating patients from their families. It damaged everything. And people need to be together in a crisis. I mean, every family crisis in a family What do you do first? You call your family, you gather. So I have no idea why we don't do that here, but I think it is important to break the barriers down. Absolutely, I fully, validate what you're saying. And if Ellie Azoulay was here, or Nancy, like people that they're really family caregiver experts, they've focused more on that, they would completely validate your comment as well. And maybe about the selection criteria for the post-ICU follow-up clinic, ask Jack to comment on that for a time threshold, and maybe John wants to comment on that too.
So let me start just to reinforce what Margaret said, because that is fully within our control, right? Post-ICU clinics are hard. They require additional resources. Who's allowed through the door of my ICU is something that, in close collaboration with my nursing colleagues, I get some input in. And I think think about how many of you in this audience right now, after 4 days at this conference, are mopey and sad and want to get home to your loved one right now, and you've been having fun. You haven't been sick the whole time. We had the experience, as so many of you did, of this sort of re-experiencing banning of everyone from the ICU as part of our infection control during the terrifying early days of COVID, and then reintroducing it. It makes, once you figure it out, and it does require supporting your bedside clinicians, it's just so much more fun if you talk to your families every day. So it's good for patients. It's good for us, too. What clinicians, what patients for the ICU, for your post-ICU follow-up, I think start where you can and move from there. So I trained as an internist, so I think a lot of these patients need great multidisciplinary primary care that their current primary care providers are often working on too fast a clock cycle, and in a 15-minute repeat visit can't second guess all the stuff that happens in the ICU. So I think it's useful if you still have folks who are often a little younger who are great general internists, as well as really good critical care docs, to send them. But I think the first part is the person who's available is the person who can start the clinic, in the same way that the first person in the room at the code is the person who calls the code. So I think it's possible for us to spend far too long thinking about who the optimal person is. Whoever it is going to need to invent a lot of stuff. Whoever's willing, get there and get started is my instinct.
And just to really add, I think, with families, from my experience too, they're just such a good source of information once the, quote, dust settles. How do their loved ones like to sleep? How do they occupy their time at home? Like, some people are readers. What kind of music do they like? And then medications. There's lots of literature showing that, what we think patients are taking at home isn't always accurate in the electronic health record. And then in the post-ICU clinic, I think it's great if there's time to have a pharmacist do a quick medication review, because we see so much polypharmacy with these medications. And some of them you can't stop right away, but we just need to figure out this whole polypharmacy issue.
Thanks, John.
Thank you so much. Any more questions? Dr. Adel again? Yes, please.
Antipsychotics for delirium. Is it time to take them away from the ICU drug shelf?
Yeah, it's a tough one. I think it depends on the intent for use. I think it is good to rigorously evaluate why they're being used, because these drugs can potentially be useful. For example, we have lots of non-mechanically ventilated patients. So, if there's a patient that's on non-invasive ventilation and they're a little bit agitated, maybe a little dose of IV Haldol is appropriate just to calm them down, because you might not want to give a lot of opioid or a respiratory depressing drug. So it's hard. I think definitely there should not be protocols that if someone's CAM positive, automatically an antipsychotic's given. I think we're beyond those days, but I know of institutions where that's still the practice. And I think it's just really the symptoms that patients are having, and thinking about, what is this real delirium, and thinking about symptoms and managing that, and thinking about the other causes for agitation. I think there's still a small role, but just, again, short use and sort of a test of change.
So John, as you said, we're not measuring delirium. And so we round the next morning, and they're now on Seroquel. And honestly, no one can explain to me how that happened. And then I stop it, and then they're back on Seroquel the next night. And that's probably only at my hospital. But do we need to, is there an antibiotic stewardship analogy here? Obviously, there aren't their externalities, but should we start thinking about default short course, such that these medications fall off automatically, as opposed to their current, right? 4% of veterans who are in the ICU stay on quetiapine for at least 6 months afterwards with no indication?
Yeah, absolutely. I think maybe I'll broaden it to all psychoactive or neuroactive drugs, because I think we start them for a reason and they just continue. And hopefully clinical pharmacists help raise some of those questions, but I still think we need far more than that to really make these drugs reevaluated constantly, and having stop orders for 24 hours for all of these things. And they can be reordered, but they just can't be continued. Great points, Jack.
Thank you so much. One more question. If not, we will conclude our session by thanking our speakers and thanking you. Thank you so much.